So our first speaker is Dr. Leen Alblaihed. Dr. Alblaihed completed our residency in 2017, after which she did an emergency ultrasound fellowship with a focus on echocardiography, because she's always had an interest in emergency cardiology. After that, one fellowship wasn't enough, so she did a faculty development fellowship and was an ACEP teaching fellow, and this past year won ACEP's Junior Faculty Teaching Award. And her area of special focus is emergency cardiology with an emphasis on emergency echo. And she's going to be spending some time with all of us talking about emergency echo. So Leen, thanks for joining.
Thank you, Amal. That's awesome. Mics are working, thumbs up? Yes, all right. Before I delve into this, because I go into rabbit holes, does anyone know who this is? No? The answer is not a transformer that I'm looking for. It is a transformer, but that's not the correct answer. What's the name of the transformer? I heard it. Soundwave, yes. So Soundwave was a Decepticon. Anyway, all right, I'm going to keep going. Sorry. I have no disclosures. This is my Twitter handle for those of you who are tweet happy and want to tweet. Also my email. If you have any questions, please send them over. And if you have any awesome cases, please, I would love to receive them. When we have patients coming in cardiac arrest, and we do ACLS, when you do chest compressions, you're essentially shooting in the dark. You don't know what's happening. You don't know why the patient coded. You don't know why the patient doesn't have a pulse. But we try everything. What if I told you you don't need to shoot in the dark? If you use ultrasound, you're able to diagnose a lot of conditions that can contribute to the patient's decompensation and manage it accordingly. I'm going to talk to you about 3 cases that I personally seen that prove to me that ultrasound does change management. Our first case is Casey. She is 34 years old, and this case hits a little close to home because Matt, her husband, was one of the paramedics that used to bring patients to the hospital. They have 3 beautiful kids. Casey wasn't feeling well for about 2 to 3 days, cold, flu symptoms, and on the 3rd day, she went down to make breakfast for her daughters. That's when she collapsed on the floor. Matt couldn't feel a pulse, started CPR, and called 911. They came, they started CPR, and Casey was brought to our emergency department with active ongoing CPR and PEA arrest. So she came to our hospital, we continued CPR, we did epi, CPR, epi, CPR, and round after round after round, I was never able to bring her back. And about an hour and 20 minutes into the code, I called time of death. And then I had to go out to tell Matt that Casey's not coming back. His children don't have a mother now, and he has to take care of them. And it was horrible. And I know you all know that feeling, that gut-wrenching feeling where you're like, was there something else I could have done? Could I have done something to change this outcome? And you know what really sucks? Is that the answer is yes. You could have done something to change the outcome. You could have ultrasounded her when she came in. Because when I did, this is what I saw. She actually had cardiac activity. It was not a PEA arrest. She was in pseudo-PEA. And I want you to remember that pseudo-PEA is a state of shock, not a cardiac arrest state. You do not treat it with chest compressions. You do not treat it with big slugs of epi. You treat it like someone in shock. Their cardiac output is so low that you can't probably feel a pulse. That's why you think they're in PEA arrest. The other thing I need you to learn is that I want you to never palpate for pulses during codes. They are erroneously unreliable. There is study after study that shows it. This study, published in Resuscitation, compared femoral Doppler to manual palpation, and guess which one did better. Look at the difference between the Doppler and the manual palpation. The accuracy, sensitivity, specificity, huge difference. They conclude that femoral Doppler has greater chances of accuracy in comparison to the manual palpation. Another study published, Resuscitation, it's a little older, and this one was actually hilarious because they had healthcare professionals, doctors and nurses, checking blood pressures on normal people with normal blood pressure. Nobody's hypotensive. And yet, they really didn't do a good job. They couldn't find a good pulse in time. They took a long time to find it, and those are healthy, volunteers with normal blood pressure. Another study, resuscitation. This one is in 2018, and it compared manual palpation to Doppler ultrasound and cardiac ultrasound. And they conclude that the cardiac ultrasound was superior in comparison to the manual as well as the Doppler, and changed management and was more accurate in detecting a pulse or not. Another study in resuscitation published. This was in 1996. It was actually a little funny because they did this study where they had 206 EMS volunteers, and they took them to, or the study was done on patients who were about to go on cardiac bypass for cardiac surgery. So we knew they didn't have a pulse. And they did this, it was the same patient control on the bypass and off the bypass. And they had them palpate for a pulse. And they didn't do a good job. 45% of them thought that the patient had no pulse when they actually had a pulse. So the patient was not on the bypass machine. They asked them to palpate. 45% of the time they did it wrong. They couldn't detect it. The other way is 10% said there was a pulse, but the patient didn't have a pulse, was on the bypass machine. And it took them about 24 seconds to read this, to get to this conclusion, which is twice as a lot of time that we know, and only 2% did it correctly. 2% out of 205 EMS volunteers. Again, don't palpate the pulse. The field trial, also published, resuscitation. What they said, this is a staggering number. They said that patients who come in cardiac arrest, who are thought to be in PEA arrest, 74.5% of them actually had cardiac activity on ultrasound. So those are patients we think are in PEA arrest. In fact, they're not. They're in pseudo-PEA. 35% of patients who we thought were in asystole had underlying cardiac arrest, cardiac activity. The other trial that was done, the Reason trial, again, huge, staggering numbers. 54% of people thought to be in PEA arrest actually had a pulse or had cardiac activity on ultrasound. Is that scary? How many codes have you done without ultrasounding people? How do you know they have an underlying cardiac activity or not? And it changes management, and it changes their outcome. My take out of this is that we really suck at palpating pulses with our fingers. Just don't do it. Forget the fingers. When you have a patient coming in, use ultrasound. You can use a femoral line or Doppler. I'll take that better than manual palpating. Bring out the ultrasound, look at the heart. Is there cardiac activity? Then they are not in true PEA. They are in pseudo-PEA. If you look at this ultrasound right now in cardiac arrest, just a show of hands, who here will do cardiac compressions? Who here will say they have a pulse? All right, this is a trick question. This is what VFib looks like. So if you see the mitral valve flickering, the patient has ventricular fibrillation. Charger pads and shock the patient. I'm going to show you a side-by-side of VFib. So you see here, ooh, this is fancy. You see here the mitral valve flickering versus in asystole on the left. You can see the swirling of blood in the right ventricle, and then there's no cardiac activity. The valves are not moving, no muscle movement, nothing. That's asystole. So what? So what if we are doing CPR on somebody who has a pulse but is so low in blood pressure that we can't palpate it? What's the harm in that? Well, if you're doing cardiac CPR on somebody with a cardiac activity, you're doing it asynchronously with their heartbeat. You're increasing the intrathoracic pressure. You're decreasing venous return. You're decreasing cardiac filling. You're decreasing their cardiac output and essentially making it worse. Plus, you're giving them 1 milligram of epi, huge slugs of epi at a time. Would you give a whole milligram of epi to somebody who's in hypotensive? No, right? So don't do it. You can cause more harm than benefit. All right, brain break. Anybody born after 1990? Can you tell me the relationship? I know this is a cassette tape. I hope to God you know this is a cassette tape. Can you tell me the relationship between a pencil and a cassette tape? All right, yes, you use it to rewind it. Cool. I showed my daughters cassette tape, although I don't have pictures of them. They never saw it. But one daughter did this, where she thought she knew it had something to do with music, and she tried to listen directly through the cassette tape. And my 11-year-old at the time used it as binoculars. She's like, so I feel very old. Our next case is Kathy. Kathy is I think she was 56 or 60 years old, doesn't matter, middle-aged lady who had a history of breast cancer, was in remission, was doing fine. She's a mother, a grandmother, and she was with her family at dinner when she collapsed. They couldn't feel a pulse. EMS came, did CPR. She came to us, did CPR. However, unfortunately, we never got her back. And in the end, we ended up calling the code. However, before we did actually finalize calling the code, I put a probe on her chest. This is what we see. Cardiac tamponade. You can't call a code if there's a cardiac tamponade because this is reversible. If you see cardiac tamponade and there's so low blood pressure, you drain the fluid, they will come back. That's the problem. Fix it. Let's talk about tamponade for a minute. 13% of people who come into your ER in Peri-Arrest have underlying cardiac tamponade. That's huge. That number is really big because I thought about all the patients who came in PEA, and 13%, that's a staggering number. When we talk about tamponade, I want you to think of two things. First of all, is this fluid truly in the pericardial space, or is it in the pleural space? Because that makes a difference. Pleural space doesn't cause tamponade. And then, if the fluid is in the pericardial space, does it truly cause tamponade or not? There are multiple views you can look at the heart. The two views that we're going to look at for tamponade are your parasternal long view and your subxiphoid view. For the subxiphoid view, simple, easy, one of the easiest views you can get. You put your probe in the subxiphoid and you look at the heart. And this is what you're supposed to see. And I'm just going to overlay an ultrasound on it so you can imagine how we see it. However, remember, you're holding the ultrasound probe, but then the probe rays come out this way, and you have to like flip it to imagine what you see on the screen, right? So it's just literally a flipped image of what you're doing on the patient. So you see the liver, the RV, LV, and this is what a normal subxiphoid view looks like. One pointer or one pearl that I usually like to give is that if you start lower than subxiphoid and you put a lot of gel and you slide your probe upwards, you can actually move that gas bubble away and you can see the heart better. So always start a little lower than you would and just slide your probe upwards. Again, this is another animation just for your imagination. It's to see why we see what we see on a subxiphoid view. That's how we get it. And then remember, I'm just flipping it because the top of the screen is where the probe is, right? This is a normal subxiphoid view, no fluid, nothing around it. And when you ultrasound it and you see a big hypoechoic area, like here, all this area, that's fluid around the pericardium. And then you need to determine if it's tamponade or not. The other view you can determine tamponade is the parasternal long view. Parasternal long, we're slicing the heart in the long view. We are getting a slice like this. And basically, you're filleting the heart open in the long view. Slicing it open, this is what you see. And I'm just going to lay it sideways because that's how when we slice it, that's what we see in the probe. And I'm just going to overlay. So this is your probe beam, right, slicing through the heart. Can you imagine the knife being the beam or the ultrasound beam? And what you see on the screen is what you're seeing on the beam itself. So I'm just going to overlay this image. Makes sense. Keep going. And I'm just going to change it into black and white ultrasound. And this is how we see the parasternal long view, right there. Again, look at the image up there. That's how you slice it, right here. I need to stop using the word slice. All right, that's how you view the heart. And then you get your RVOT up there and left ventricle, right ventricle. This is a parasternal long view that I took of one of the patients, and I'm going to freeze it for a second just to show you. So this is parasternal. This red dot is your descending aorta. And that's what you need to focus on when you're determining if the fluid is pericardial or pleural or pericardial. You can see here that blue dot, that's the fluid that's running in that space, will track anterior to the descending aorta. Any fluid that tracks above or anterior to it is in the pericardial space. Any fluid that tracks posterior is in your pleural. So here, again, you could see fluid tracking above, anterior to descending aorta, that is in the pericardial space. fluid that's tracking below is in your pleural space. And it's really important to determine which is what. All right, let's talk about the fun stuff. Tamponade. When I say tamponade, I want you to think of impedance of the chamber filling. So the pressure in the pericardium, the sac, is actually big enough to stop the filling of the chambers. Which chambers will be affected first? The right-sided chambers, your right atrium, right ventricle. So when does your right atrium fill? Think about it. It fills when the tricuspid valve is closed. That's all I want you to remember. When your tricuspid valve is closed, your atria should be filling, right? Your ventricles should be ejecting blood. So you're in systole. So anytime you're in systole, with the tricuspid valve being closed, look at your right atrium. If there's right atrial collapse, then worry about tamponade. Likewise, if the tricuspid valve is open, that means your ventricles should be filling right now. And if there's something impeding or hindering that filling because there's pressure on the outside, then you worry about tamponade. So you see the small arrow up there? That is inbowing of the right ventricle during diastole. That is bad. That is concerning for a tamponade. If you can't get a subxiphoid, you can get it in the parasternal long view. And you use your mitral valve as a surrogate for your tricuspid valve. If your mitral valve is open, we are in the ventricular filling. Makes sense. So that's when you look at the right ventricle. If it's collapsed inwards or there's inbowing of the right ventricle, you worry about tamponade. Here it is in the clip, basically. So you can see there's inbowing of the atria as well as the ventricle. You can also measure the fluid. We do this in patients who are not actively dying. And it kind of helps you determine how much fluid there is. So if there is anywhere between, if the thickness of the fluid around it, if you measure it, is about 1 centimeter, you're talking about 100 cc's of fluid around it, so small. If it's anywhere between 1 to 2 centimeters, then you're about 100 to 500 cc's. But if you measure that fluid to be more than 2 centimeters, please take pictures and send them to me. That is a large pericardial effusion. Right? Remember, tamponade means that there's hindrance of the filling of the right side of the heart, right? So your IVC will be plump. So if you're not sure, put the probe on your IVC. If the IVC is big, that's a surrogate for your CVP. That gives you more of a hint that this patient might be in true tamponade. One clinical pearl, what I noticed working in the community, is that we always wait till the last minute before we actually drain the fluid. There's no need to wait until your patient is clinically unstable. If you're unable to get the patient to a cardiac cath lab in time and you see signs of tamponade, drain the fluid before they code. All right, my last brain break. Can anyone tell me what this is? Oh, now you can't tell me. What is this? Oh, yes. Okay, Ben got it right. An A-track. I personally didn't see one. But funny thing is, after I started searching this image, I started getting AARP advertisements, and I was looking into it. So if you've ever used an A-track, maybe it's time to consider this. All right. Our third and last patient is Fatma. And Fatma is a mother of a student who actually come studying in Maryland. She visited him from Egypt. 3 days later, she had collapsed at her home. EMS were called, and they put her on the chest compression device. And they brought her to my ER in chest compression. She came to my ER, chest compressions going on, epi given, chest compressions, epi given, round after round after round. I managed to get the ultrasound probe in there, and this is what I saw. Very high concern for pulmonary embolism in the right setting. There's evidence of pulmonary embolism, which changed the management, right? So now I'm calling for thrombectomy, or I'm giving TPA, or thrombolytics. So let's talk about PE for a minute. Pulmonary embolism, you got a blood clot that comes to the right side and wedges itself in the pulmonary artery. What happens is your right ventricle is trying to eject blood through that pulmonary artery, but it can't because of the obstruction. Pressures go up in the right ventricle. That will cause dilation of your right ventricle. Too much pressure on the walls, so everything kind of just like widens out. You have widening of the tricuspid valve that will cause tricuspid regurg. You have widening of the right ventricle. And what's worse is that now that the right ventricle is wide, it starts pushing on the left ventricular chamber. And that's what kills patients, is that the right ventricle septum now is pushing into the left ventricle, so it has a smaller chamber, smaller cardiac output. That's how patients die of massive PEs, low cardiac output. You can see this in almost any image. So here, apical four-chamber, you can look and you can see that the right ventricle is bigger than the left. That's not good. Another thing you can do when you're doing your apical four-chamber is to make sure you're in the right plane. A lot of residents, when they're scanning, they would be a little bit oblique, and you can falsely make your right ventricle look bigger if you're not in the right plane. Make sure that when you're looking at your apical four-chamber, your septum's in the middle, and you're looking at both the tricuspid and mitral valve opening and closing, like this. This is a correct view. So you have to see both valves open, close, your septum's in the middle. That's how you know you're in the right plane and not oblique. And this is a good way, or this is a good view to start measuring, or just eyeballing if the right ventricle looks much bigger, like here. This is a bad sign. Again, in your parasternal lung, you can take a look and see that the right ventricular size is big in comparison to the left atrium and aortic outflow. This is concerning for high pressures and or high volumes. Again, this is a parasternal short. You can see the right ventricle huge in comparison to the right ventricle. And in this view, I want you to focus on the septum and how the septum moves. And so the septum is moving or inbowing towards the left ventricle. And this is bad. This is called the D sign because the left ventricle actually looks like a D. And this kind of denotes that there's high pressures or volumes in the right ventricle that's actually impeding or obstructing the filling of the left ventricle. So that's bad. So whenever you see this in a patient who is coding or peri-code, you know that the treatment's changed, right? You're not in the ACLS box only. You need to get TPA or thrombectomy or ECMO or something until they remove this obstruction. So remember, when you're looking at your patients, you really don't need to shoot in the dark anymore. You can get your ultrasound. Remember that Pseudo-PEA is a state of shock. It is not a cardiac arrest state. Treat it as shock. Don't use chest compressions. Don't give big slugs of epi. And the only way you can know the patient is in Pseudo-PEA is if you look at the heart. Tamponade is a mimic of cardiac arrest or PEA. Look at the heart and drain that fluid. Stick a needle in it. You'll bring the patient back. It is a reversible cause of death. PE, you need TPA or thrombectomy, not just your ACLS. So remember, you're going to think outside the box. And this is what I mentioned earlier, is that when you ultrasound people, it will change your management. They're all not one etiology of death, right? So please reach out to your ultrasound with every cardiac arrest or a very sick patient. Thank you very much. That is my time. If you have any funny pictures or nice, please email it to me. Nice pictures. Thank you.
All right, we've got a couple minutes for questions. Any online? Dr. Miller, go ahead.
We have one question from Peter, who asks that he thought that there was evidence to suggest that RV dilation was not uncommon in cardiac arrest, well, regardless of whether there's a pulmonary embolism as like the original concern. And the second question is, how does one interpret RV dilation in the setting of underlying core pulmonale? So like a
Perfect,
pulmonary.
great. And that's why I said in the right setting. So that is correct. After cardiac arrest, RV dilation is pretty common that we see. But if the patient had a sudden cardiac death, has risk factors for PE, and they're already dead, and I'm doing CPR, if I see that right ventricle being huge, I will reach for TPA as a last-ditch effort. If the patient is brought back and has ROSC and hypotensive, I will call my thrombectomy team to see if this is a patient for candidate for ECMO or thrombectomy. And then, sorry, the second question was in core pulmonale. Again, it's really hard to tell. Patients usually with core pulmonale will have right-sided RVs that are bigger. But again, the story matters, right? If this patient's sitting up and talking to me and they feel fine and their vitals are relatively okay and they're not hypoxic with a big RV, that's not new that the patient had it before, right? So again, in the clinical setting, it makes a difference. Yeah, sorry, go ahead.
We have one last question that just came in from DBK, and they ask relative to a recent experience that they had where it sounds like the patient had a small hypoechoic strip indicating tamponade, but there was very minimal pericardial fluid draining. And the question is, how aggressive should the aim for the draining be? And is there any association to the downtime for the patient in terms of when you should attempt to drain or not?
Okay, so remember pericardial tamponade doesn't depend on the size of the fluid, it depends on how fast the fluid accumulates. So you can have small tamponades that have accumulated quickly that will cause, small effusions that accumulated quickly that will cause tamponade. So if the patient doesn't have a pulse, or if there's any sign of right atrial collapse, right ventricular collapse, right atrial should be one of the earlier signs, I will try to stick a needle in there. And remember that you need to look at it in multiple views, not just the subxiphoid. Look at the peristernal long and try to see. I wonder if one of the mimics of pericardial effusion is the pericardial fat pad. And so I wonder if that is what had been seen before. But again, effusion, you can see it. If it's going to cause tamponade, you're going to see it in multiple views and not just the subxiphoid view. In terms of how fast you should drain it, was that the second part of the question? Or
I guess the question was like, how aggressive should the drainage be? Maybe a reference to like
I would,
volume fluid drained.
I would drain it until I get a pulse back, essentially. You can keep the drain in and send them up to cardiology or ship them out to cath lab. Sometimes they keep the drain in there. But usually when you take that fluid out, they should regain ROS.
For answering those questions, we had a few that came in just in the last few minutes, and it sounds like we'll probably save those for the panel.
Perfect.
But I appreciate your
Thank you so
responses.
much.
Finished early, you're still on the hot seat.
Oh, okay, cool.
So
Great.
for the other speakers,
Last time
keep
I
that in
finished
mind.
late. Last time I finished late. Instead I finished early. It's like,
All right. If there's any questions from the audience, please just raise your hand also. Otherwise, I got texted a couple of questions.
if you want to talk about transformers, we can do that too.
Or we can do questions. All right. So, all right. So let's see. One person was asking, because there's such a strong focus on not interrupting chest compressions, you had started out by saying that you should never check a pulse with your fingers,
Correct.
but obviously doing the echo takes a little bit of time. How do you balance that?
So with the echo, I always have my probe in place while chest compressions are going. And whenever they do the rhythm checks, I would hit the record button as I'm looking at the heart. And after that 10 seconds and start compressions, I will go back and look back at my video because it's sometimes hard to determine and you'll take more time. So just record it, just click that record button and then determine afterwards once they're doing compressions that, hey, did you see cardiac activity or not? Oh, that's what I mean.
Subcostal view?
Subcostal is one of the easiest and depends on, and I actually sometimes like the apical 4, especially when the patient is on the cardiac compression device that rhymes with Fucus. Sorry. You can actually get a good subcostal view too. So any view really you could see.
All right. And questions? All right.
Okay.
The other question I got had to do with, you had also mentioned at the beginning to not do chest compressions with pseudo-PEA.
Yes.
A, what's the harm in that? And part B, if there is harm, how do you balance that with the fact that in pediatrics, it is recommended you do compressions even with the heartbeat, but when the child's heart rate is slow?
I was worried about that question, and I should have looked it up about the pediatric one, but let me answer the first part. The harm is, so if you're doing chest compressions on somebody already with a pulse, you are increasing the cardiac intrathoracic pressure. You're doing it asynchronously with their innate heartbeat, and you are hindering filling of the heart, hindering filling or cardiac output. So you're making things worse. They're trying to maintain a cardiac output, and you're just interrupting that. So that's bad. In terms of peds, I really don't have a good answer to like why, but I know in peds, like even if they're bradycardic, you start chest compressions. I don't know how to, I don't know. Adults are not, I don't know. Peds are, I don't know. I'm not gonna make it up.
So they're not just little adults.
They're not little adults. That's why I did not do pediatric EM.
All right. And the last question was, are they developing ultrasound probes that are big enough that you can continue doing compressions while at the same time visualizing the heart? It's not a serious question, I think, but
There's the TE, the transthoracic echo. Transesophageal echo, the TE that we do. So a lot of centers do that. You just stick that in, and that's it. That's great view. You get a view right there, and you can, when you pause for checks, you can have your cardiac view right there without kind of finagling it. So, all right.
all right.
Thanks.
For the people online, if there's any other questions you think of, please send them in. And the Q&A panel at the very end oftentimes gets the best reviews because there's so many great questions, so just send them in, and we will put all of our speakers on the hot seat during that final panel, and that's why I don't speak at this conference.
I'm looking forward to it. Thanks.
All right, thanks so much, Leen.